One of the consequences of the complex American healthcare system is really uneven quality of care. In some parts of the system, we have peaks of greatness, where we do outstanding care and really do fantastic services to people. But there are also valleys of quite poor care that we should be embarrassed about. This unevenness is a real problem, especially because we spend $3 trillion on healthcare, much more than any other country. When we consider quality of care and what we mean by quality of care, we typically divide it into three buckets. One bucket is safety, avoiding accidental or preventable injuries, errors, and harms. A second is efficacy, providing services that we know are going to increase our quality of life, decrease our mortality, decrease our morbidity, using medical services to improve our long-term health. And the last are a bunch of other things that people consider important, making sure care is equitable, you get it in a timely way, that it's patient-centered. First, let's focus on safety. The American healthcare system is not terribly safe. 1 in every 25 hospitalized patients, that's 4% of hospital patients, actually suffers a hospital-acquired infection. That is, they get an infection in the hospital, and those infections can be deadly. The Institute of Medicine estimated that almost 100,000 people die per year because of hospital-acquired infections. We should not be proud of that. And then there are other medical errors. Operating on the wrong body part, taking off the wrong leg, for example, having a prescription misfilled, or prescribing a drug to someone that they're actually allergic to. These other medical errors can cost as much as $30 billion per year. Overall, when the experts have looked at the safety of the American healthcare system, it's an embarrassment. If you look at scheduled airline trips, there's less than 1 death per 100,000 encounters. Flying on an airline is incredibly safe. On the other hand, getting medical care is about the equivalent of bungee jumping, 1 death for about every 1,000 encounters. Should medical care be like bungee jumping? What is the cause of these safety deficiencies? Well, again, when people have studied it, it turns out to be the complexity of the healthcare system rather than individual problems. Of course, there may be a few bad apples, but that doesn't contribute to all these problems. Most of the problems arise from errors of communication and management, not to lack of clinical performance and skill. That means to solve the quality problems and the safety problems requires focusing on improving the hospital system and the healthcare system overall. We're not just worried about the problems of safety in the system, we also worry about efficacy. That is, are we getting the right treatments that are going to reduce our mortality, reduce our morbidity, and improve our quality of life? Now, typically what we really care about is having good outcomes. That is, making sure we're in optimal health. Sometimes it's pretty easy to measure outcomes. 30-day mortality after a heart attack is a relatively easy measure. Is someone alive or not alive within 30 days? But a lot of other things aren't so easily assessed. For example, in cancer, we're typically interested in 5-year mortality, and 5 years takes a long time to assess. So in those cases, we don't look typically at the outcomes, but we tend to look at process measures. That is, looking at things that we think are related to the outcome of 5-year survival, like did people get the right chemotherapy? Did they get the right follow-up exams? When we look at the quality of care that Americans get for reducing their mortality and morbidity, we're really good at some things, and in particular, cancer. So if we look at the mammogram rate in the United States compared to all other developed countries, we're very close to the top. Similarly, if we look at 5-year survival for things like breast cancer or colon cancer, again, compared to all other developed countries, we're typically very close to the top, if not number 1. But we're not so good at many other things. In 2006, the RAND Corporation, a think tank in Los Angeles, did a very important study about the quality of care in the United States. They looked at Medicare patients discharged from hospitals, and they looked at whether they got recommended care. This was care that is known to produce good outcomes. For example, were people with high blood pressure, did they have their blood pressure measured, and if it was high, was it well controlled? People who had high cholesterol, was their cholesterol measured? And if it was measured and high, was it well controlled when they were discharged from the hospital? It turns out that overall, Americans received only 55% of recommended care. That's almost like the flip of a coin. And if you look at specific areas like high blood pressure, 2/3 of people had their blood pressure measured, and if it was high, it was well controlled. But that means 1/3 of the people either didn't have their blood pressure measured, and if it was high, it was not well controlled. Similarly, for cholesterol control, one that was particularly unimpressive was related to people who got admitted to the hospital for community-acquired pneumonias and were not given a vaccine against those pneumonias when they were discharged. Another area we haven't done so well on is hospital readmissions. Before, it used to be that when a Medicare patient was discharged from the hospital, they had about a 1 in 5 chance of being readmitted to the hospital within 30 days. That is not very impressive. Now, this has been changed and altered by the Affordable Care Act that has penalized hospitals that have high readmission rates. Another assessment of the quality of care is the utilization and outcomes of patients. It turns out if you look at a map of the United States, the amount of resources used to treat patients with the same diagnosis varies widely. Some areas, we spend a lot of money and give people a lot of treatments and procedures. And then when we look at the same areas by the outcomes for those conditions, like heart attacks, turns out that spending a lot of money is, again, not clearly related to improved outcomes. Where we do a lot of things, people don't necessarily turn out better. In addition, even though we overall do well in cancer, it turns out that the survival rate from one region of the country to another can vary widely. In colon cancer, for example, it's known that Hawaii has better survival rate, better 5-year survival rate than, say, New York City. And there's substantial differences. Why does geography matter to people? It really shouldn't, and we should be embarrassed that you can live longer because you're in one state than another state from cancer. Measuring quality turns out to be a big challenge too. We can measure some aspects of quality, but overall, to assess hospitals, a lot of people rely on U.S. News and World Report and their best hospital rankings. But when you unpack those rankings and actually look at how they're done, they have only one real data point. Most of their ranking depends upon things like reputation, or do they have certain equipment like robotic surgery that has not been shown to be related to improved care. So going forward on the quality issue, we need to have improvement. We need to measure better how we assess the quality of care and measure it more consistently and in real time. Second, we need to improve things that we know how to improve, like hospital-acquired infections, and drive them down. And third, everyone needs to be invested in improving the efficacy of the system and ensuring people get the proven care that we know leads to better outcomes. That's going to be the big challenge for the healthcare system going forward. Next, we're going to look at medical malpractice, something that's on lots of people's minds and is also part of the American healthcare system that's broken.